Welcome everyone, and to the first panel discussion with the three speakers who, or the two speakers who need no further introduction. But I'd like to introduce Dr. Hall, who's the Chief Executive of the UK Tea Infusion Association.
Hello, thank you for the introduction, Nadine. Before we get into the panel, I'd just like to say fantastic talks in that first session, really enjoyed them. And I think based on the session, we can already say that tea is the ultimate superfood and we should all be drinking more.
That's great. So let me start off with a question as everybody in the audience starts to hopefully join us through the chat function. But one question I'd like to start with is that one thing that's very current, and that's really the introduction of precision nutrition, sometimes called personalized nutrition, which brings with it new research approaches for integrating genomics and metabolomics and the microbiome and other factors for determining individual responses, the notion of one size doesn't fit all. What do you see as strengths and limitations of such efforts to understand the interindividual variability in responses to tea, and how can it contribute to the kinds of research that we need to do for tea research? Anybody want to start?
Do you want me to start, Jeff, or Taylor? I don't mind. I think it's a really interesting thing, isn't it? Because I think what we do know about human beings is that they're incredibly variable in their responses. And we've learned quite a bit from nutrigenomics about different, let's say, propensities for or susceptibility to things like Alzheimer's disease being related to certain alleles and how diet can affect our risk, whereas with some people being very much protected by adhering to a high, a healthy diet, and others it having less effect. I think also when we talk in relation to my talk, I talked about stress quite a bit. And we all know that, one person's stress is another person's excitement. Those of us who love a roller coaster are very different to those of us who would be terrified by that experience. So I think very often when we think about personalized nutrition in relation to something like tea, it will be about what works for you and also the feelings that it can create. And I know that the middle speaker, who isn't here, talked about subjective cognitive decline and how, that he did say, that is related to development of dementia. And I just want to reassure people it's not very directly related. But there are things that we can do to manage our stress, manage our subjective experiences, and that, tea and healthy nutrition and exercise and so on will be part of that bigger package.
Those are good points. Dr. Wallace?
I think personalized nutrition is probably growing faster than, what researchers can handle. I see on the consumer side through my blog and, everything that I do, industry is going to, I think we're in the phase where industry is going to create 23andMe-like tests, and dietitians are going to begin to offer tailored diets, that are tailored to your genetics. And I think that's exciting. I think from, a cautionary standpoint, it is, maybe too big of a promise of hope for somebody that maybe has an allele for chronic disease, at this point. And so I think we have to be cautious how we talk about it to consumers, but I think it's a fascinating area of research. One of the things I think that is very, at least what our research has shown, is that tea is universally safe as a beverage. And so for me, it's, not even just the personalized approach, but that, tea gives another option that could replace a soda or a sugar sweetened beverage, something like that. And it's safe, universally for people. And so I think it's a good recommendation because not only could a certain portion of the population that's genetically predisposed really, really benefit from it, but that it's universally safe. And I think we can be comfortable with recommending a modest amounts.
If I can just come in there, one issue around personalization is how realistic is that? should we be thinking more of stratified nutrition? Because if you think of industry trying to, produce new functional products, it's going to be pretty hard to cover the wide range that might be needed for a personalized approach. But there may be, 5 products that, that are required, different doses of flavin-3-ols or whatever that are required, depending on your age or, genetic background or how you metabolize these things. So I think maybe there's more realism around that stratified approach, a fully personalized one.
Yeah, and to build on that, Aideen, I think it's interesting to consider the variability of different types of teas, because teas can vary hugely depending on what climate they're grown in, the season, the type, how they're processed. So I think that's another layer of complication on that personalized nutrition, isn't it? How do we give meaningful recommendation doses if what is tea to many people is very different?
Yeah, well, and consumers are going to begin to look at it. I know, having, a parent that passed and, that had cardiovascular diseases, I've looked at my 23andMe and, there are certain websites you can start looking at these alleles and, tailoring your diet. I mean, I have as a scientist, so other people are looking as well.
Yeah, but I would add, one thing to think about is not so much just translational, but in terms of precision nutrition research, one of the approaches of the N of 1, where you're really focusing on one individual, but you're monitoring that individual very frequently, which you don't do in regular randomized clinical trials. So the idea that we could have monitors, like we have 24-hour glucose monitoring, and we have 24-hour blood pressure monitoring. I don't believe we have a wearable device for stress quite yet, but Dr. Dye, you can tell me. But the idea that we don't have to recruit a large cohort and hope that everybody is equally stressed or equally depressed, but we can look at them individually and follow them very frequently for changes in cognitive performance or in mood. And so that research approach, which is kind of the thinking of precision nutrition, might have value just in new research designs.
There's also an element, Jeff, of looking at people in their real environment versus taking them into the laboratory. And if you look at people in your real environment, then, we measure appetite in the laboratory or stress or whatever on an hourly basis. In the real environment, you might experience it in a very different way. So what's opening up now with sophisticated statistical techniques and other designs is things like ecological momentary assessment. So being able to say, you tell me when you experience this thing rather than when I measure you. And that will give us a great deal more insight into the kind of rhythms and factors that predict how people change in response to stress, what actually causes them to stress. And there are some kind of like little Apple Watch type things that do measure cortisol. They're not that great at the moment. But, when we started off 15 years ago measuring ambulatory glucose monitors, they were not the easiest things in those days. They're pretty cool now. So these technologies will run with us and we can use them and enhance, to enhance the research that we do. But it really does need to be kind of well controlled and appropriate. And like you say, the variability within studies is one of the problems.
Dr. Cassidy, do you want to raise an issue while I search and curate the list? Thank you.
Sure. So another issue in relation to tea and health is that a lot of the data that we have comes from the large population-based studies. And we've got some really important data showing that very small amounts of tea can have very significant impacts on cardiometabolic health and actually, as we saw earlier today, vascular dementia as well. But for the trials, most of them are very small and short term. And Taylor, you mentioned the wonderful Cosmos trial, which is kind of a very long term endpoint trial with the flavin-3-ols, but from the cocoa source rather than tea. So, what do we need next? Do we need a large, longer trial? And do we need to better understand, how these things work? What's the mechanism of action? What are your thoughts on that?
Well, I'll say, we're researchers, we always think we need to have more data. So yeah, I think a large control trial with hard outcomes and measurement of biomarkers consistently it would be a good thing. But look, in nutrition, we're limited, right? There's limited public funds for nutrition. There's limited things that you can actually do to humans. So you have animal studies that, you can, dissect the animal tissues, the flavonols build up and what metabolites and things like that that have their utility. Large prospective cohort studies. I mean, if you saw the forest plots in my presentation, they're consistent. They all kind of line up, the same way. And I think that, when you have consistency among epidemiological studies, you have small randomized control trials showing effects on multiple biomarkers. You start to the laboratory studies with animals and in vitro studies. You have this, kind of totality of evidence that you have to look at. And Jeff wrote a wonderful paper about this. Oh gosh, it was probably when at my days, at ILSI, back in the 2012, 2013, something like that. That really highlights why all this different type of research matters. And so I think that as a nutrition researcher, we have to look at all of that. And I think epidemiology is just one piece of the puzzle that we have to take in to make recommendations.
Yeah.
I think it's that needle in the same direction for all of the elements of nutrition research. That's what we need. Sharon, what do you think from an industry perspective? So something like the Cosmos trial, costs a lot of money, but starts to give you more definitive data than the small short-term trials that we've done up to date, which are relying on biomarkers like lipid levels or blood pressure. But what would a trial look like to industry? What would the interest be in something of that scale?
Well, I think it's sort of referred to in Louise's talk, and I have a follow-up question for Louise as well. But in terms of ultimately, we would like a health claim that you can use on pack. And to have that health claim, Louise has shown it's very difficult to get it through all the hurdles, particularly through the EFSA hurdles, and I'm sure it's the same in other markets as well. So what is it that the researchers can do to give us clearly defined? I mean, I know the gold standard is double-blind randomized control trials for EFSA, but they still fall, don't they, because of the caffeine. So how can we positively position the caffeine? And the other question, Louise, the second one, is you talked about doing studies on healthy participants. Do you think there's value in doing studies on participants who have defined health issues, such as, in this case, clinically depressed or suffering from anxiety?
I think, firstly, let's talk about the claims. I think the claims were kind of introduced to sort of protect the consumer and to, actually to stimulate innovation, but they very much have gone down a pharmacological route. And what we're comparing here is a nutrient that's available in food using a methodology that we would use for pharmacological interventions. And I think you said yourself that what the components of the tea will vary depending on the soil, the sunshine, the variant, how it's treated, and all of those kind of things. So that natural variation will be really hard to take into account in a trial. And actually what you want to show in a claim is that whatever that product is, it's particularly well characterized, and that it will have the same effect in any kind of form later on. And that's almost unobtainable in a way, isn't it? It's really setting the goalposts in a very difficult way. And I think that there may be much more benefit to the kind of soft marketing, because I think the key thing that was said earlier is that it's nothing harmful about tea. Yeah, so, and not in the daily doses that one might consume. Yeah. And when I talk about tea now, I'm talking particularly about black tea and green tea. I'm not talking about herbals. I think that's a very different ballgame. So in terms of that well characterized, I guess you can do that for black tea. What you notice in a lot of the trials has happened is that they've used active ingredients in capsule form, because that's about giving a dose in a way that is, in a pharmacological model. So I think the health claims is very difficult territory to navigate. Yeah. But that's not to say that you can't talk about tea in a positive way. Yeah. So I don't know if that answers that first part of your question. I think the other aspect in terms of cognition is that if we only do studies on people who are cognitively really fit and healthy, we have to do a hell of a lot to them to actually show an effect, which is kind of why I went down the stress route and said, look, okay, we've got these studies of giving ECGC and things like that. They show some minor effects. It's mostly confined to these very difficult, demanding tasks related to attention. So that says something about mechanism of action, but it also says these tasks are really hard and we need to give them really hard tasks because they are performing at peak level anyway. If we then introduce stress, what we're trying to do is tip those people off their perfect performance platform and say, in a situation where their performance would normally be impaired, are we being able to maintain that performance under conditions of stress? So I guess that is an argument for saying that tea might be more beneficial if you are not at your peak on that particular day.
Yeah, and I should just mention my colleague Shabnam has popped up in the chat because they do have a health claim for green tea in Canada. So if people want to look in the chat,
I saw that too. I'm interested. Yeah, it's really interesting.
I'll play, devil's advocate here a little bit. As someone who is currently running a large RCT of 1,200 6-month-old infants, I will tell you that large RCTs are very difficult, and they also have their limitations. If you look at the Cosmos study, for instance, and I think it's a very beautiful study, the PI and I are good friends. It's a 3-year duration, and when you look at the multivitamin arm, one of the things I've argued is it's not long enough to show an increase in cancer development on there. So you have to take the time that you can keep all, 20,000 plus people on a pill that's adherent, and pills are easier than food. We've seen that as being editor of Journal of Dietary Supplements. It's easier for me to get you to take a pill one day than have, 2-3 cups of tea. You have the control that you have to have over 20,000. Lose a lot of control over their background diet and other dietary components. And then you have the healthy effect. You have the healthy person effect that, healthier people tend to enroll themselves in randomized control trials in nutrition. So there's a lot of variability in large randomized control trials that can sometimes mask the results.
Well, let me just add one thing that is a real gap in our knowledge base right now. And I think, Dr. Wallace, you referred to it earlier. That's we have no biomarker for tea intake. We have no biomarker for flavonol intake, so that we, regardless of what kind of tea you drink, whether it's white or green or oolong or black, that we could measure in the blood just how much you've been consuming, how quickly you're metabolizing it to active or inactive ingredients. And this is where I think when we go back to talking about precision nutrition, the idea of having a metabolomic profile of tea consumption that is unique to tea or to flavin-3-all intake would provide enormous power about who's complying and biologically what individuals are appropriately or best metabolizing them. So that's an area of research I think that would have big payoff for all of the other kinds of research designs, whether observational or interventional.
Yeah, definitely. I mean, and I think omics technologies will eventually get us there. I showed the one publication by Dr. Kugel's lab in the beginning of my presentation, that began to look at, biomarkers of flavin-3-all intake, but it's hard. I mean, you've got different compounds for, different sources of flavin-3-alls and, just the difference in chain length and, even quantification using HPLC is still hard for some of the longer, oligomers when it comes to flavin-3-alls. So.
Right. So let me, we have just about 10 minutes left in the discussion here. So let me get down to a big question. I mentioned gaps in our knowledge. What are the gaps other than a lack of biomarkers that we really need to fill? And what priorities should we have? I mean, is it more important that we study T and immune function or T and cognitive function? Are there certain designs that are going to be better suited for different outcomes when we talk about doing new T research?
I think those are good questions, Jeff. I've also been looking in the chat, and people are talking in the chat about cohort studies,
Yeah.
and moving away from that kind of occasional measurement type thing. I guess also I'd be very keen to see that real world evidence in people who are vulnerable, but not impaired as such. So 2 of the studies that I discounted from my review were in people who'd already scored very low on a mini mental state examination. So they already had not quite dementia, but they were well on the way to dementia. And we know that we can't bring people back from dementia, even with the pharmacological drugs that we have available on the market at the moment. So in a sense, that boat has already left. And what we need to be looking at, in my view, are people who are vulnerable. So people at middle age, for example. There was some nice information about in Taylor's talk about tea and obesity, and some of those mechanisms that were talked about in the middle talk around blood pressure lowering, all of those kind of things where we could have some objective outcomes as well, but that would also show that vulnerability and that protective element for later decline. So if you thought about my cognitive curve, if you like, I think one of the really beneficial things that we can do is slow that trajectory of decline, because that's the thing that matters to us all, isn't it? Is having a healthy, long old age when we can be physically and cognitively independent. And anything that can help us to do that, I think, will be really valuable.
You know, the UK Biobank has done a really good job at looking at using NMR to look at, blood metabolites, a whole array of blood metabolites. It's like we need cohort studies that do the dietary assessment and then also look at the blood every year or ever so often.
I'm laughing because I'm a participant, Taylor.
But I think Joyce raised a very important point in the chat, that even if we address the gaps in the research, ultimately, I think it comes back to Louisa's comment about soft marketing, that what we put out there has to be in consumer friendly language. People have to understand what that benefit is to be encouraged to increase their tea consumption.
And I think that's one of the problems with the claims at the moment, Sharon. They're so rigid in the language that they're allowed to use. And I looked at the claim in Canada, and it's very much on very biological hard outcome stuff, isn't it? It's not on cognition or stress. And I think one of the problems with some of the EFSA claims is that you can have a claim on appetite and satiety using a visual analog scale. It says, how hungry are you at one end? Not at all, extremely. You cannot have a claim on stress using the same scale. How stressed are you? Not at all, extremely. Because they don't see that as being comparable. But I see that as a psychologist as measuring exactly the same thing, your subjective rating and how you use that scale.
Right.
I think
I would add, go ahead, Dr.
Sorry. I think the dissemination is very important, and Taylor highlighted the FMD data, the flow mediated dilatation data, where you see very significant clinically relevant changes in FMD with small amounts of tea. And yet that's important, not just for heart health, but also for brain health.
Yeah.
But how do we explain FMD to consumers so they really understand what that means and the magnitude of change that they can get?
I understand the value to consumers and even to the industry of making explicit health claims. But I also think maybe an even better approach has to do with dietary guidance. And, as Dr. Wallace said, tea is really safe, but it's more than safe. If you substitute 0-calorie tea for sugar sweetened beverages, that's a huge win. And what we need to do is educate people as to what are the more nutritious beverages to drink and which are the more harmful. And when I look at the data, tea comes out right on top as having these dietary bioactive components that seem to promote health in important ways, but more importantly, it doesn't have the negative attributes which are so clearly harmful.
Well, to add on to that, I had it in the back of my mind to say in my presentation, and I never said it. When you look at the systematic review of prospective cohort studies, those prospective cohort studies, you check off, I consumed a cup of tea. It's not apparent whether that was sweet tea or unsweet tea. And so you see these effects across prospective cohort studies, but we can assume that a large portion of these individuals are consuming sweet tea. And we also know that these flavin-3-ols, before they were these powerful antioxidants, back in the 1940s or so, we knew of them as anti-nutrients because they blocked carbohydrates from being absorbed. So extracts and things like that to the food industry may have an even greater utility in, can I put this in a coffee cake? Can I, mitigate some of the sugar that's in tea with higher levels of flavin-3-ols in the product? I don't think we know the answer to that yet, but I think there's a lot of potential for that type of research.
Yeah. And I would say, Jeff, I think you've hit the nail on the head with that positioning, because we funded a study of by the Tea Advisory Panel in the UK to look at tea benefits through the ages, so review the literature. And we just happened to publish that paper when the government was putting out its nutrition strategy, which talked about children drinking less sugar-sweetened beverages. And the two came together, and journalists picked up on that and said tea's a great option from 4 years and above. So a great win, and just a message that's easy to understand, I think.
So we just have a couple of minutes. Does anybody see a question in the chat that they want to respond to briefly?
There is a question, well, there's an implied question around the health profiles of countries that drink tea more or less, so that epidemiological evidence. And I don't know if anyone knows anything. It's not my expertise, but I think it's an interesting natural experiment in a sense, isn't it?
Yeah, that becomes a big challenge, because if you look at different tea drinking in different cultures, different countries, the background diet is different. And so it's not like everybody was eating the same diet and some countries were drinking tea and others were not. So it becomes a challenge to disaggregate those incredibly confounding factors.
And I think that was something that was raised around the Cosmos trial too, is that you get wide variability in the baseline flavin-3-ol levels. And actually you may well get better benefits in those who are depleted in flavin-3-ols and are gaining from the intervention. And I noticed in the chat there's one saying the outcomes of the Cosmos trial, do they relate to other sources of flavin-3-ols? And yes, of course they do. There are slight differences in the profiles, but actually, if flavin-3-ols are beneficial from cocoa, you would expect to see similar benefits from tea and other sources like apple as well.
Yeah. And I think especially Cosmos can be translated with the safety data, because it's a very, very high dose flavin-3-ol RCT that's long term. And I think that very much, we in our academy clinical guideline, we very much considered particularly the safety of that trial, as relevant to broad flavin-3-ols.
Right, and I would remind you that many of the big successful randomized clinical trials with a nutrient intervention, including Physicians Health Study, the Women's Health Study, Cosmos Now, when their trial intervention arms are complete, most of these studies continue as prospective cohort studies. So they have this really interesting baseline with that period of intervention, and then they're going to follow them into the future. So I would look forward to seeing what the results from those established cohorts are going to show us. So we have 1 minute left. So I just want to say thank you very much for a robust discussion. That for the audience, we have a 15-minute tea break. And the next talk will be on tea and cancer prevention by Dr. Raul Zamora Ross from Spain. So please have a nice break and come back and join us in 15 minutes. Thank you.
Thank you.